three very interesting clinical cases. We haven't curated these in any way, so we haven't chosen the slimmest woman with the baby in the perfect condition. We've positioned, so not condition, what we've done is we've taken cases that you would see in your fetal medicine practice, wherever you practice all over the world, and show you some of the imaging and discuss the management and diagnosis of the case. So we're going to go straight to colleague and friend Medat, who is going to lead us into case one.
I'm going to start with the first case straight away, which is entitled ventricular disproportion. So I will start with a quick background about the patient. So this patient is 24 years old. In her first pregnancy, had a scan elsewhere in the first trimester, which has demonstrated a large nuchal of 2.7 millimeters. She had a discussion about the options, and she opted for NIPT, which has showed low risk of aneuploidies, chromosomal abnormalities, basically. And then she was referred later in the pregnancy for a second opinion, as the anomaly scan showed a suspected ASD. So we saw her at Sidra for the first time at 22 weeks. And the first view, the first impression straight away is that that was something far more significant than ASD. So just to describe what we're looking at, basically the heart appears to be univentricular with a small potential space on the side, which is gives the appearance of a ventricular disproportion or a hypoplastic ventricular hypoplastic heart. For the sake of orientation, the left of the baby was towards the top and the right was towards the bottom of the image. This is the same view with the color Doppler. This has demonstrated a blood flow which was significant on the normal size ventricle or the large size ventricle and atrium, and there was almost no blood flow at all on the smaller ventricle. So the first question is which ventricle is normal and which ventricle is small, and that takes us back to the orientation of the baby, how the baby is lying. So if you look at the video on the left hand side, I'm doing a quick sweep of the baby from the head to the bottom. This baby was a breech presentation, long lie, and the spine of the baby was towards the left of the mother. So again, that confirms that the left is up and the right is down. And if we look at the heart view itself, the normal size ventricle was towards the right side, and it appeared to be anatomically and morphologically as the right ventricle, as we could see the moderator band, and because of the thickness of the wall. And the smaller ventricle is on the left side. That gave us the diagnosis at that stage of a hypoplastic left heart syndrome. Again, on a live video, we can see that the same view, left is up, right is down, blood flow only univentricular on the right hand side. And as we go up on the views, we can see what is supposed to be a 3 vessels view, but it only shows 2 vessels. So this is effectively what we're looking at. So this is the right ventricle, the small potential space is the left ventricle, the right atrium, and we could barely see the left atrium at all. So a predominant right ventricle, which is slightly enlarged with a relatively larger pulmonary artery, as this is currently the ventricle that supports the fetal circulation. 3 vessels view on the left and on the right. On the grayscale, only 2 vessels are seen, and there is the top one is the pulmonary artery, and the one at the bottom is the superior vena cava. And again, the same view with the color Doppler. The pulmonary artery seems to be slightly enlarged, normal superior vena cava, and we could not see or demonstrate the aorta at all. Again, for the sake of demonstration, pulmonary artery in the top, superior vena cava on the bottom. And on a sagittal view, we could see clearly the ductal arch, but the aortic arch could not be demonstrated as well on the scan. To add more complexity to the case, because we performed the full anatomy scan or anomaly scan, I diagnosed agenesis of the cerebellar vermis or vermal agenesis, and there was bilateral renal pelvic dilatation of around 8 millimeters and 6 millimeters. And that would obviously make the situation more complicated because there are multiple anomalies. You would start suspecting an underlying chromosomal or genetic abnormality. So that confirmed the diagnosis of hypoplastic left heart. There was no ASD seen, and the ductus arteriosus was patent. The patient was referred for the MDT as expected, and she had a repeat echo that confirmed the findings, and the couple had consultation counseling about the prognosis and the possible outcome. So very briefly to go through the features of hypoplastic left heart, the left ventricle is small or non-existent, hypocontractile and hypotrophic, may look globular on some occasions, may be bright if there's endocardial fibroelastosis. That was not the case on our side. The right ventricle is dilated, it traps under the left ventricle apex, and it forms the apex. So it's the apex forming ventricle. Ascending and transverse arch are very small, can be difficult to demonstrate on ultrasound on some occasions, and there can be retrograde filling of the arch, which makes the baby ductal dependent. The pathology basically is a no flow, no growth syndrome. There is stenosis or atresia, which causes no blood flow in the ventricle and causes arrest of the development of the size of the ventricle. So it can either be atresia of both mitral and aortic valves or aortic vessel. It could be stenosis and atresia, or it can be stenosis and stenosis. So it is a common condition. It can be 2 to 3 cases per 10,000 live births. It accounts to 2 to 3% of all congenital heart diseases. It's more common in males than in females. And if untreated, unfortunately, it is responsible for a high mortality or neonatal cardiac death, up to 40% of cases. It can be associated sometimes with a chromosomal aneuploidy and microdeletions, such as Turner's, Jacobson syndrome, trisomy 13, trisomy 18, and the George syndrome. But in the majority of cases, it's only a developmental problem and not associated with a background chromosomal problem. It can also be linked to a single gene mutation, which is NKX25, according to a recent research. The presentation depends on the size of the ASD and the patency of the ductus arteriosus, the presentation at birth. So babies can be temporary asymptomatic if no restrictive ASD. They become symptomatic with PDA closure as the pulmonary vascular resistance falls. Neonates with restrictive or intact atrial septum are symptomatic at birth straight away. They are cyanotic. There is inadequate intra-atrial mixing of oxygenated and deoxygenated blood, and that's why they appear cyanotic straight away, and they carry obviously worse prognosis. So the differential diagnosis can be either functional, which includes other causes of cardiac cyanotic and non-cardiac cyanotic diseases of the newborn, or it could be structural, the conditions that might look similar on ultrasound, such as double inlet left ventricle, severe aortic stenosis or coarctation of the aorta. Just due to the lack of time, I will stop there, but I will be more than happy to take you through the consultation, the prognosis, and the outcome of this case. Thank you very much.